I'm Carla Floyd-Slabaugh, the occupational therapist, here to see my patient, Jacob Slabaugh, in room 204 in the ICU unit. Jacob has suffered a traumatic brain injury. He's in a minimally conscious state. I have checked with the nurse. She has told me he is okay to see. I do need to monitor his vitals, so I'm going to start with that. Currently, as he's resting here, his heart rate is at 80. His respiration rate is at 30. His blood pressure is 132 over 87. His intracranial pressure is at 20, and his arterial line is showing a blood pressure of 132 over 87, the same as the blood pressure cuff. Making my initial observations with Jacob, he's laying in here in the bed. He hasn't responded to my voice yet, which could be consistent with somebody that's in a coma. I see this line. This line is measuring the intracranial pressure, so that means that wire goes into past the skull, so I don't want to damage that at all. He has an IV over here. I don't want to lose that, but that is not a as important as some of the other lines I see here. I see a blood pressure cuff. On this side, I saw on his chart when I read that he has an arterial line. That means that this IV goes into an artery. If I were to move this or something happened to that, I could prick the artery, which would be quite a source of a bleed, so I don't want that to move in any way. And the nurses actually have put an IV board here to prevent that risk from moving. So as I'm doing my full assessment, I won't be able to assess range of motion of his wrist. I also see here with Jacob, he has his sequential SCD, sequential compression devices. Those are working. And just looking at him, before I moved his arm, kind of had a little bit of flexion in this left elbow. I see this left leg is externally rotated with a little bit of knee flexion. That makes me think that he might have some increased tone throughout this left side. So far, Jacob hasn't responded in any way, and as a minimally conscious client, I'm going to kind of think he's probably in a Rancho level 1, 2, or 3, and I'm going to see how he's responding to cognition, vision, olfactory, pain, proprioceptive, vestibular, range of motion. I'm going to be looking at tone management and bed positioning. So, Jacob, my name is Carla. I'm here to see you today from occupational therapy. I'm just going to touch him a little bit to give a little bit more input, kind of thinking about that sensory input. As I try to straighten this arm, I'm getting some resistance. This is consistent with increased tone. So I'm going to be firm and see if I can straighten that arm out, because I wouldn't want to have a range of motion loss there. Along with that increased tone, he's going to like to stay positioned in internal rotation of the shoulder. So I'm going to do some external rotation, see if that stays there. Jacob, can you squeeze my hand? I'm going to squeeze his hand to see if I can get a response. I'm going to be patient for a minute to let that sensory input go in. Let his brain process. Squeeze my hand. I feel like I'm getting a slight response. It's rather weak, but that was a response. So he heard me and followed a command. That was really good. The other thing I want to do is see how responsive he is to pain. So with that, I can push my nail into his nail bed And that's what we call more of a generalized response. You can kind of see the whole body responding, as opposed to a more localized response where if I give pain, just that one extremity would withdraw. Instead, we saw a more generalized response with that pain. So with providing some sort of pain, I did that. I saw my response, so I really have no need to continue providing some sort of pain. We could do some, his eyes are not open yet, so I'm hoping maybe as I continue to provide stimulation that will happen. Right now they're not open, so I'll hold off on the vision. And I'm going to move forward to some olfactory stimulation. I'm going to do that with these extracts. I have coffee extract here, and so I'm going to put a little bit on my Q-tip. I also have a little bit of lemon extract. I'm going to put that on a different Q-tip. I do not want these two Q-tips to cross. Because the body has the ability to accommodate to olfactory information very quickly, I'm going to provide the stimulus and then remove it. And so I'm going to go kind of slowly under his nares to see if he has any kind of response to the olfactory stimulation. And I'm seeing his nares flared. So he smelled that. That was, I provided stimulation, and there was a motor output. You could see his eyes, his eyebrows did rise, and his nares flared. I might come back in a few minutes just to see if he has a different response to the lemon. So not quite as strong as the coffee, but that's nice that he could have a couple of responses to two different stimuli there. I want to assess his range, so I want to be very careful with this arterial line, but the nurse has told me that it's okay for me to look at everything else on the arm. So this does have the IV board here. I want to provide a lot of support to this arm, and I'm going to see if his range is intact. I'm getting a lot of resistance here, but with tone, I'm going to be gentle and see if it will let me take this shoulder into full range. So with the positioning of that, I did need to bend the elbow, but I was able to get this arm up into some good shoulder flexion and some good external rotation. I'm curious if it's a little more tight if I come out here with external rotation. I'm going to want to maintain that because that's going to be an issue with bathing and dressing and putting on deodorant. His shoulder coming back to neutral was good. I can continue to go back and forth just to provide some range. I can check out the elbow, getting some resistance with this movement, so I could rate that with the Ashworth scale. I am not going to test the range of the wrist, but I can also look at his digits. So a little bit of tone here too, getting some resistance, and I don't want to lose that range of motion. After I do the range, I can leave that arm positioned a little bit in a better position. I'm going to take off the SCD to do the range with his lower extremities. One thing that's happening here, as he's laying in a very dependent position, his feet are going down into plantar flexion, and that will mean he will lose range of motion in his ankles if they're not positioned properly. So here, I want to look at the hip, knee, ankle, and the toes. And so bringing it to neutral, more of a out of that external rotation. I can bring that hip up, go into hip extension, external rotation look good, go into some internal rotation, knee extension. With him resting in this position a lot, he could lose that ability to fully extend the knee, so I'm going to want to keep that there. And then because he's spending so much time in bed, I'm also going to want to stretch that ankle. Okay. One of the things I haven't done yet is providing proprioceptive input. That is, proprioception comes from the muscles and the joints to let us know where those body parts are. And I'm going to do that by providing joint compressions. So I'm going to go shoulder, elbow, hand, and on down the extremity, the lower extremity, and then repeat on the other side. I could do joint compressions at his head. It just so happens with the intracranial pressure monitor, I'm going to choose to skip that for now. So I'm going to start here at his shoulder. I'm not going past the elbow. I'm going to come proximal to the elbow, and I'm just going to compress this joint. I'm going to shoot for about 3 to 5 repetitions. Same thing here. 1, 2, 3. I'm going to skip the wrist. I'm going to come to the digits. 1, 2, 3. This is joint compression, not joint traction. So I'm only giving a little bit of input to be able to compress the joints. Sometimes after that type of joint compression and proprioceptive input, you can feel relaxation of that tone, and it can help you with your positioning. For his lower extremities, I'm going to provide proprioceptive input as well. But if I come down to his foot and prevent the knee from bending, I can actually hit the hip, knee, and ankle all at once. And then because it's spending so much time in bed and not getting normal stimulation, I want to be sure to provide that joint compression to all the toes as well. So let me double check our vitals. So initially the vitals were what they were. After providing some stimulation, I'm noticing the vitals went up a little bit. His heart rate went up a wee bit. The respiration rate is now at 30. His blood pressure also increased. I'm noticing a difference between the reading in the blood pressure cuff, which is 133/78, and the reading of the art line, which is 137/92. The art line is going straight into the arterial supply, so this is the more reliable. Probably as I was moving him around, it just wasn't able to make a good reading on the blood pressure cuff. So for my documentation and my decision making, I'm going to pay attention to this reading. And his intracranial pressure has increased from 20 to 22. So not a terrible increase, but something I'm aware of. So I feel like his vitals have gone up a little bit. I should keep an eye on that. So to help provide some calming input, I'm going to continue with the joint compressions. So I'll do the same thing over here on this lower extremity. I'm going to do the same thing on this arm. Joint compressions to the shoulder, joint compressions to the elbow. Here I can do the wrist and all the digits. After providing that proprioceptive input, I now see that his vitals have decreased. They've kind of settled down a little bit. His heart rate is down to 79. His respiration rate is at 29. The intracranial pressure has come back down to 20, and the arterial line BP is 130/85. So you'll notice that that proprioceptive input, which can be so calming, can help calm down some of the things happening with the minimally conscious client as well. I have yet to provide any sort of tactile input. So Jacob's family brought in this scented lotion. This is his girlfriend's favorite lotion. She really likes this scent, so that'll help stimulate the limbic system, those memories, and so I can provide some tactile input, even deep pressure as I'm just being a little more, I won't say forceful, but being more, in a way, heavy-handed with that. He said the family said he really liked this scent. This isn't an obnoxious scent to him, so it wouldn't be a bad thing to put this scent on his body. So again, providing a lot of tactile input and deep sensory input to try to wake him up. So far he has not opened his eyes, but the nurse is coming in now. She needs to change the pad under his bottom and change the adult brief, and so with that I'll be helping her roll him back and forth, and with that rolling we'll be able to stimulate the vestibular system. And so I would normally be on the other side of the bed to help with the rolling. I'm going to bring that foot up. I'm going to bring this arm over, looking to provide support at the scapula and the hip, and helping roll. The nurse is going to help clean him up. While she's getting her supply, she said it was okay if I do a little bit more rolling. So now we're getting some nice input to that vestibular system. The nurse has him all cleaned up. I'll help him roll back. And now his eyes look like they want to open. So I can do a little bit more with the visual. So his eyes are open. I'm not getting him to make eye contact with me, but I'm going to provide something to try to really give a, oh, he followed it ever so slightly. So not a tremendous amount, but a little bit, like that's trying to emerge some tracking. You can see he's still continuing to just kind of look blankly in space. So because he just had his accident, he doesn't have any range of motion limitations, but with his increased tone, he is at risk for losing that range. I can grade the level using the Ashworth scale of how high that tone is. I can do the same thing on this side, looking at each one of the joints and kind of giving a grade to that. Now as I'm looking to end my session, I want to position him properly. So I'm going to put the SCDs back on. He will get repositioned every 2 hours. That will be from the right side to his back to the left side to his back, and kind of go like that. The nurse has already told me that he still needs time on his back. It's not time for him to roll one way or the other, but I have some problems with the way he is positioned here. We could do better. One thing is his lower extremities. I'm going to do a quick measurement to see what size boots he's going to wear. So I can take that measurement and order the boot, and that'll be a positioning device so he doesn't lose that range of motion in his ankles while he's recuperating. For right now, I'm going to use some pillows to keep his ankles at 90. And now, because his upper extremities are wanting to stay in this elbow flexion, I want to position them in shoulder external rotation with elbow extension. And he likes to come into a lot of adduction. I'm going to want to avoid that as well. I want to be careful with this arterial line. I'm going to work with this tone. Bring this arm out. So now I have a little bit more space, getting away from that full adduction, putting the arm in elbow extension and letting it rest here. And I'm going to do the same thing on that other side. In a hospital bed, I would do a better job getting to that other side. Okay. One last thing I didn't share is if Jacob wasn't doing a good job responding to me, he did give a hand squeeze to my command to squeeze my hand. But if he wasn't responsive, one of the things I could do is try to arouse him more. And that could be, as he's laying there rather non-responsive, one of the techniques I would use would be to provide a lot of auditory input, and you can see he had a response with that. So after I've gone through my session, I go back and look at my vitals again, and I record these vitals. His heart rate is actually down nicely. Now it's at 77. His respiration rate is at 28. His blood pressure is at 129/83. I'll look at the arterial. And his intracranial pressure has decreased from 20 to 19. So that can happen, and that when you first provide stimulation, those vitals may increase, but especially after the proprioceptive input and some of the things that can be more calming and decreasing the anxiety, that you can have a decrease in the vitals. So I'll let the nurse know how he's positioned and how things went, and I'll plan to see Jacob again tomorrow. Thank you.